You are a physician trained in Pediatric Advanced Life Support. You are working in the pediatric clinic when a mother brings her 6-year-old son into the clinic. The mother states that the boy has had vomiting and diarrhea for the last 2 days. He quit eating and drinking yesterday. Another team member takes vital signs and notes that the pulse is palpable but weak at a rate of 160 beats per minute. Blood pressure is 100/62, and respiratory rate is 28 breaths per minute. You ask the nurse to start an IV. You attach a cardiac monitor and see this rhythm. You measure the QRS duration and note that it is 0.08 seconds. 1. You recognize this rhythm as A. Possible ventricular tachycardia. B. Probable SVT. C. Probable sinus tachycardia. D. Sinus rhythm. Correct answer, C. Probable sinus tachycardia. The normal QRS, less than 0.09 seconds, fast rate but slower than in SVT, and the presence of one normal P wave for every QRS complex would lead you to believe that this is sinus tachycardia. You identify that the rhythm is probably sinus tachycardia. The boy's blood pressure is stable at 100/62. He is tired but is responsive. His pulse is still weakly palpable at 130 beats per minute. Capillary refill is delayed, and the boy's skin is pale, cool, and mottled. 2. You determine that the child is displaying signs of A. Cardiogenic shock, B. Hypovolemic shock, C. Distributive shock, D. Neurogenic shock. Correct answer, B. Hypovolemic shock. The signs, symptoms, and history of the present illness would all lead you to suspect that the child is displaying signs of hypovolemic shock. 3. You know that all of the following are signs of hypovolemic shock except A. Narrow pulse pressure, B. Weak peripheral pulses, C. Breath sounds with crackles on auscultation, D. Decreased urine output. Correct answer, C. Breath sounds with crackles on auscultation. Crackles can be heard in patients presenting with cardiogenic shock. Distributive shock caused by anaphylaxis may produce wheezing lung sounds. Obstructive shock, as seen with a developing tension pneumothorax, will produce decreased or absent lung sounds on the affected side. Hypovolemic shock is usually associated with clear lung sounds. However, the sick child with fever and pneumonia may be volume depleted with coarse bronchi lung sounds present. Four. You suspect that the child's shock is A. Hypotensive, B. Compensated, C. Decompensated, D. None of the above. Correct answer, B. Compensated. At this point, the child's compensatory mechanisms have resulted in a blood pressure that is within normal limits. However, the clinician should understand that shock can be present even with normal blood pressure. Children with both hypotensive, previously known as decompensated, and compensated shock are at risk for deterioration, and the team must implement interventions to prevent progression to an arrest state. The child's respiratory status remains stable with an open airway and adequate respiratory effort and oxygen saturation of 96%. His blood pressure is 90/62. The nurse is attempting for the third time to insert an IV while the child is sitting upright on the stretcher. 5. The most appropriate next intervention is to A. Establish interosseous vascular access. B. Provide ventilation via bag mask device. C. Lower the head of the bed. D. Continue to monitor the child. Correct answer, A. Establish interosseous vascular access. The child has an open airway and good oxygenation. The blood pressure is decreasing but still normal, so the child should be allowed to assume a comfortable position. The team must begin to give the child fluids, and the nurse is having trouble starting a peripheral IV, so the team must attempt IO access. The team prepares to insert an IO catheter. 6. Appropriate sites for an IO catheter include all of the following except A. Tibia, B. Femur, C. Anterior superior iliac spine, D. Ulna. Correct answer, D. Ulna. The ulna is not an appropriate site for IO insertion. With some of the newer devices, the team can consider the humerus. However, most clinicians will prefer to use a site in the lower part of the body, which allows better access to the site during chest compressions and resuscitation efforts. The team inserts an IO catheter into the left proximal tibia. The team is preparing for the administration of fluid. 7. The preferred initial fluid recommended for this child is A. Blood, B. Colloid, C. Hypertonic crystalloid, D. Isotonic crystalloid. Correct answer, D. Isotonic crystalloid. The initial resuscitation fluid should be an isotonic crystalloid solution, such as normal saline or Ringer's lactate. Although you can use a colloid solution, they are usually less readily available than a crystalloid. You hang the bag of normal saline. You estimate that the child weighs 35 kilograms. 8. For hypovolemic shock, the correct amount of isotonic fluid for a child is A. 10 milliliters per kilogram as a bolus over 5 to 20 minutes. B. 10 milliliters per kilogram as a drip over 60 minutes. C. 20 milliliters per kilogram as a bolus over 5 to 20 minutes. D. 20 milliliters per kilogram as a drip over 60 minutes. Correct answer, C. 20 milliliters per kilogram as a bolus over 5 to 20 minutes. 9. For this 35 kilogram child, the correct amount of isotonic fluid as an initial bolus is A. 500 milliliters, B. 700 milliliters, C. 800 milliliters, D. 1000 milliliters. Correct answer, B. 700 milliliters. For a 35 kilogram child, multiply 35 kilograms times 20 milliliters per kilogram equals 700 milliliter bolus. You deliver the bolus of fluid. As you reassess the boy, you notice that there is no change in his condition. 10. Your next intervention is to A. Repeat the bolus of fluid. B. Increase the amount of fluid to 30 milliliters per kilogram and bolus again. C. Decrease the amount of fluid to 10 milliliters per kilogram and bolus again. D. Do not repeat the bolus of fluid. Correct answer, A. Repeat the bolus of fluid. Fluid boluses should continue until the child's blood pressure and perfusion are improved. Remember, hypotension is present if the systolic blood pressure is less than 70 millimeters of mercury plus age in years times 2 millimeters of mercury. After the second bolus of fluids, the boy's vital signs are stable, and he is more alert than earlier. He indicates that he needs to urinate. You prepare to transfer him to the care of the pediatrician in the pediatrics unit.